All right, today we're talking about a true master of disguise in medicine, celiac disease. Now, if you're a medical trainee, listen up. This is one of those conditions you absolutely need to have on your radar, mostly because it almost never, ever presents the way you think it will. So let's jump right in with a classic clinical puzzle. Picture this. You've got a patient in front of you. They're complaining about some vague, kind of unrelated stuff, maybe some iron deficiency anemia. They're always bloated and just chronically tired. So, what's the one diagnosis that could actually tie all of that together? Well, the answer is often hiding in plain sight.
Yeah, the Great Mimicker. We're not kidding when we call it that. Celiac disease is way more common than you'd think. But, and this is the crazy part, it gets missed so often that it's basically created this hidden epidemic of people who are either misdiagnosed or, just not diagnosed at all.
Okay, so just how big of a problem are we talking about? Get this, an estimated 3 million people in the US have celiac disease. Just let that sink in for a second. 3 million. That is a massive number of people for a condition that, honestly, just flies completely under the radar most of the time. And here's the real kicker. The vast majority of those cases, they go completely undiagnosed. And it's not because celiac is rare. Not at all. It's because the clues are just so subtle, so misleading that they send clinicians down all the wrong paths. That's why learning to spot them, well, that's the whole game. So let's get back to basics for a sec. What exactly is celiac disease? Well, at its heart, it's an immune reaction to gluten. That protein in wheat, barley, and rye. When someone with celiac eats gluten, their own immune system basically launches an attack on their small intestine. That damage is what causes all the problems with malabsorption. And please remember this, it's not a food allergy. This is a full-blown systemic autoimmune disease. Huge difference. All right, uncovering the clues. This is key. If this thing is missed so often, how in the world are we supposed to find it? Well, to catch this mimicker, you have to know what you're looking for. And here's the secret. The most important clues, they often show up miles away from the gut. Okay, let's start with the classic textbook stuff. These are the GI clues you probably learned about in class, right? Signs of malabsorption like steatorrhea, which is just a fancy word for greasy, foul-smelling stools, plus the usual suspects like belly pain and bloating. But here's the thing. If you're only looking for these, you are going to miss most of your cases, for sure. But this is where the real detective work comes in, the non-GI clues. Honestly, this is where you're going to make the diagnosis in the real world. Unexplained iron deficiency anemia is the #1 sign, the absolute classic. And it makes total sense, right? The damage is happening right in the part of the intestine that absorbs iron. But your radar should also go off for things like other vitamin deficiencies, bone issues, infertility, or even something as vague as chronic fatigue or slightly off liver enzymes. I really want this number to sink in. Up to 15%, 1/5, of patients who get an endoscopy just for unexplained iron deficiency anemia end up having celiac disease. Seriously, if you take away only one thing today, let it be this connection. Iron deficiency anemia with no clear cause, you have to think celiac. It's a huge trigger for testing. Okay, so you're suspicious. Now what? How do you actually confirm it? This is the diagnostic pathway, where we gather the hard evidence to finally unmask this thing. Whoa, stop. Before we talk about a single test, we have to cover the most critical point of this whole process. The patient must be eating gluten. I'm going to say it again. They have to be on a gluten-containing diet for the tests to work. If they've already gone gluten-free on their own, the antibodies can disappear, the intestinal damage can start to heal, and you'll get a false negative result. You'll miss the diagnosis completely. So, the actual algorithm is pretty straightforward. Step 1, like we just said, make sure they're eating gluten. Step 2, you run some blood tests for specific antibodies. And step 3, if those tests come back positive, you move on to an upper endoscopy with biopsies to get the final definitive proof. Now for those blood tests. Your first-line test is the IgA-TTG antibody. It's a fantastic test, super sensitive and specific, both around 95%. But there's a trap. If your IgA-TTG test is negative, but you're still really suspicious, you have to do one more thing. Check a total serum IgA level. Why? Because some people are just naturally deficient in IgA, and if they are, their IgA-TTG test will be falsely negative no matter what. It's a classic pitfall you need to know about. All right, let's wrap things up by looking beyond just the diagnosis. We're going to talk about a really important associated condition and then boil this all down to the key takeaways you need for your practice. Okay, check out this connection. It is incredible. This rash is called dermatitis herpetiformis, or DH, and it's ridiculously itchy. Now look at the numbers. Only about a quarter of people with celiac get the rash. But look at it the other way around. It's staggering. Pretty much 100%, 100 of people with this specific rash also have celiac disease. It's basically celiac of the skin, and if you see it, the diagnosis is a slam dunk. So let's nail down the absolute most important points to take away from all this. Number 1, celiac is common, but it gets missed all the time. Number 2, it can present in a million different ways and very often has 0 GI symptoms. Number 3, I'm going to say it again, always think about celiac in someone with unexplained iron deficiency anemia. And finally, number 4, don't forget all your tests are useless unless the patient is actually eating gluten. So I'll leave you with this final thought for your next day in the clinic. Your patient's labs come back, and they've got this mild but persistent elevation in their liver enzymes. The whole initial workup comes back negative. So before you just slap on the label idiopathic and move on, ask yourself, have you considered celiac disease? Because it might just be that hidden link you've been looking for.